All right, so here is a brief overview of preoperative nursing care. So when we're talking about surgery, the decision to perform the surgery can be based on several different kind of purposes. So we have curative surgery. This is performed to resolve a health problem by repairing or removing the cause. So if somebody has, a bad appendix, we do an appendectomy. We take out the appendix that cures the problem. We have palliative surgery. We do this to relieve symptoms of a disease process, but it does not cure the process. So we might do a nerve root resection to help with pain. We might go in and take out parts of a tumor to make it smaller so that the person is more comfortable. But the palliative surgery is just for comfort. It is not going to cure. We have cosmetic procedures. So these are performed primarily to alter or to enhance personal appearance. So liposuction, revision of scars, a rhinoplasty, something like that. Uh, Another one that we do is so functional, which is similar to palliative, but it's just a type of surgery that we're doing to help somebody function more optimally. So this would be maybe they have bad arthritis in their knee, and so they have a knee replacement surgery. Um, Another one that's not on the slide, but just to keep in mind, is we do surgery sometimes diagnostically. So we will do that surgery to determine the origin or the cause of a disorder. So that would be like a biopsy. We go in and do a breast biopsy, or we do an exploratory laparotomy where we just open up the belly, take a look around, try to figure out what the problem might be. We also classify surgery based on the degree of urgency that's involved. So we have emergent, urgent, required, elective, and optional. So the most common is elective. So this is a procedure that is planned. We schedule it in advance. We know what's going to happen. This might be, a hernia repair, maybe a cataract removal, that total joint replacement that I mentioned. Those are elective surgeries. An urgent surgery, this is something that's going to require prompt intervention. It might be life-threatening if we delay more than like 24 to 48 hours. So this is something, an intestinal obstruction, maybe a bladder obstruction, some bone fractures. One we'll talk about this quarter is acute cholecystitis. So this is a gallbladder attack. And then the next stage is emergent. This is something that requires immediate intervention because of life-threatening consequences. So this is your gunshot, it's your stab wound, any severe bleeding, an abdominal aortic aneurysm, something that needs to be addressed right away. So most people are going to enter the hospital a couple hours prior to surgery. They're going to have all the necessary medical assessments prior to the surgical intervention. The surgical period is followed by a recovery period of a few hours in the PACU, which we'll talk about, and then the patient returns home. So a lot of times that'll all happen within one day, and we call this ambulatory surgery, which includes outpatient, same day, or short stay surgery that does not require admission for an overnight hospital stay. So this is anything that is 24 hours or less. With our more invasive procedures, or if our client has a lot of comorbidities, they might need to be admitted to the hospital prior to the surgery and then remain for several days post-operatively for monitoring and for evaluation. Our traumatic and our emergency surgeries, they most often result in prolonged hospital stays. So the preoperative phase, this begins when the decision to proceed with the surgical intervention is made, and it ends when the client is transferred onto the operating room table. Obtaining informed consent is a big part of preoperative care, as is a thorough assessment and identification of risk factors. And we're going to go over each of those in more detail. So in the preoperative setting, a thorough assessment is very important. The nurse needs to report any abnormal assessment findings both to the surgeon and to the anesthesia provider because it might not be safe to continue with the surgery. A good cardiovascular assessment is vital because cardiac problems cause as much as 30% of our surgery-related deaths. We also, of course, want to pay very close attention to both respiratory status and renal status. And then keep in mind that most patients have some degree of anxiety before surgery. Some of our clients might be very fearful. It's important that we perform a psychosocial assessment to determine their coping ability and their support systems. Anxiety can actually influence the amount and the type of anesthetic needed, and it can slow down their recovery. And then severe preoperative anxiety is also linked to higher degrees of pain that some patients experience after their surgery. So we have, enhanced technology, we have expertise, but surgery is still a complex, stressful experience, whether it's elective or emergent. And even healthy patients having outpatient surgery can experience unanticipated complications during what's supposed to be a pretty simple procedure. So some of the risk factors for surgery. If the person has any signs or symptoms of infection, there's going to be an increased risk of sepsis. If they have anemia, this can have negative effects on oxygenation and it can impact their ability to heal. Hypovolemia can cause circulatory compromise. Electrolyte imbalances can lead to dysrhythmias. Age is a factor because older adults are at greater risk of operative complications. With pregnancy, there's always fetal risk with the anesthesia. Any respiratory diseases such as COPD, pneumonia, or asthma can lead to compromised respiratory status. Cardiovascular disease like stroke, heart failure, MI, hypertension, these can all lead to cardiac problems during surgery. Diabetes mellitus, this decreases intestinal motility, it alters your glucose, and it delays healing. And liver disease is going to alter medication metabolism, which is important both during and after surgery. Some additional risk factors to keep in mind. Renal disease can cause altered elimination of some of the medications that we use during surgery. Some of our endocrine disorders like hypo or hyperthyroidism, Addison's disease, Cushing's syndrome, these can all affect how medications are metabolized, and they can also cause electrolyte imbalances. Immune system disorders, they can make a person more susceptible to allergic reactions, and any immunocompromise can alter ability to heal after the surgery. Coagulation defects, those increase the risk for bleeding. Malnutrition can result in delayed healing. Obesity has an impact on anesthesia, on elimination, and on wound healing. Use of some medications, such as antihypertensives and anticoagulants, those can cause operative and postoperative complications. Substance use like tobacco or alcohol, those can affect the way a person responds to anesthesia, and it might require some dosage titrations. And family history is really important. For instance, a family history of malignant hyperthermia places a person at higher risk for this complication, which we'll talk about when we talk about intraoperative care. And then allergies. They might be allergic to latex or even to the anesthetic agents, which would certainly complicate the procedure. Some older adult considerations. They are at greater risk for operative and postoperative complications for several reasons. So they tend to have decreased cardiac output, they have increased blood pressure, and they have decreased peripheral circulation. So it's really important that we monitor their vital signs. We are checking their peripheral pulses, and we're checking their capillary refill. So if we have really strong baseline data before the surgery starts, This is going to help them detect any deviations or identify any problems early on if they start to arise. Elderly also have reduced lung capacity, they have loss of lung elasticity, and they have decreased oxygenation of their blood. So it's important to monitor respirations, monitor their breathing effort, and we want to teach coughing and deep breathing exercises because those will be very important after the surgery. And then in our elderly, we can also see decreased blood flow to the kidneys and a reduced ability to excrete their waste products. They have slower reaction times. They have decreased ability to adjust to changes in the surroundings. They have increased issues with immobility due to osteoporosis or arthritis. And they have dry skin with less subcutaneous fat. So this makes the skin at greater risk for damage, and then the slower skin healing also increases their risk for infection. It also makes them less able to maintain adequate body temperature, and I don't know how many of you have actually been in an OR, but they're typically kept really cold, so this is a pretty legitimate issue with a lot of our elderly patients. So depending on how emergent the surgery is, we typically do a whole bunch of diagnostics to help determine whether the patient's a good surgical candidate and also to identify any issues that we might need to watch out for. So a urinalysis, this is done to assess abnormal substances in the urine. So we're looking for protein, glucose, blood, bacteria. We always do a blood type and a cross match so that we can be ready to transfuse blood products if necessary, if we have any bleeding issues during the surgery. A CBC gives us an idea of any underlying infection, and it can help indicate immune status. A hemoglobin and a hematocrit, these indicate fluid status, and they also alert us to whether or not the patient is anemic. We always do a pregnancy test in women of childbearing age because of the fetal risk from anesthesia. We assess bleeding risk by doing clotting studies. We also need to know if there are any electrolyte imbalances so that we can correct them if possible. So potassium imbalances always need to be corrected prior to surgery. Hypokalemia slows recovery from anesthesia and it increases cardiac irritability. And hyperkalemia increases the risk for dysrhythmias, especially with the use of anesthesia. So we're going to look at those electrolyte levels very closely and correct them as necessary. We also want to assess our renal function by looking at our serum creatinine. We are going to do a baseline ABG. This is important to assess any of our patients with chronic pulmonary problems before they go into surgery. A chest x-ray gives us an idea of heart and lung status. Often our young healthy adults are not required to have a chest x-ray, but a chest x-ray determines the size and the shape of the heart, the lungs, and the major vessels. It determines the presence of any type of pneumonia or tuberculosis, and it also just provides baseline data in case of complications. So any abnormal x-ray findings are going to alert that surgeon to potential cardiac or pulmonary complications. Heart failure, cardiomyopathy, pneumonia, infiltrates, these are all reasons that we might want to cancel or at least delay a surgery, especially if it's elective. For emergency surgery, those x-ray results can assist the anesthesia provider in selecting what type of anesthesia to use. And then a 12-lead EKG might be required for all patients older than a specific age who are going to have general anesthesia. So that age is going to vary among facilities, but it's usually about 40 to 45 years. And it's also going to be ordered for patients with a history of cardiac disease or those who are at risk for cardiac complications. So during your assessment, it's going to be very similar to your other nursing assessments. You are going to find out about any past medical history, anything that they're allergic to, medications or, substances like latex. We want to know what medications they're currently using and when the last dose was of each of those meds. We need to find out about any potential substance abuse because we don't want to see any interactions with the meds that we're going to give them. Again, we're going to look at any potential psychosocial problems. We're going to look at anxiety. We're going to look at fear, any issues that are potentially going to make their recovery process more difficult. Make sure you take care of that in a cultural context as well. So look out for any cultural considerations. Review those lab results. See if there's anything that needs to be reported to the providers. We're going to still do our full head-to-toe assessment, pay special care to heart and lungs, and then make sure you get that full set of preoperative vital signs. Another big part of preoperative care is informed consent. So this is the patient's autonomous decision about whether to undergo a surgical procedure. So voluntary and written informed consent from the patient is necessary before any non-emergency surgery can be performed. So this is to protect the patient from any unsanctioned surgery, and it's also to protect the surgeon from any claims of an unauthorized surgery. So consent is a legal mandate, but it also helps the patient to prepare psychologically because it helps to ensure that that patient understands exactly what is about to happen, what surgery they're going to have, why, and what the alternatives are. So as the nurse, you can ask the patient to sign the consent form and you can witness the signature, but it is the surgeon's responsibility to provide a clear and a simple explanation of what that surgery will entail prior to the patient giving consent. So as the nurse, you can clarify the information that has already been provided, but if the patient requests additional information, you need to notify the surgeon. So as the nurse, you are not responsible for providing detailed information about the surgical procedure. Your role is just to clarify facts that have already been presented by the physician. So during this informed consent process, the surgeon also needs to inform the patient of the benefits, the alternatives, any possible risks or complications, and he or she should also tell the client what to expect in the early and the late postoperative periods. So the nurse, you need to make sure that that consent form has been signed before you administer any medications, because consent is not valid if it is obtained while the patient is under the influence of any medication that can affect judgment and decision-making capacity. Patients deserve, and they rightly demand, to be informed and involved in decisions affecting their care. So it is that client's right, it's their absolute right as a competent adult to refuse treatment for any reason, even when that refusal might lead to death. So for example, in the case of Jehovah's Witnesses, some patients will not accept blood transfusions because of their religious convictions, and that is absolutely their right. There are a few caveats to this informed consent process, though. So if a person can't sign, like if they physically can't write, he or she can write an X in place of the signature, and that consent has to be witnessed by two people. And then in a life-threatening situation in which every effort has been made to contact the person with medical power of attorney, consent is desired but not essential. So in a life-threatening situation, we just proceed as if we have consent. The other big part of preoperative care is teaching. So there's a lot of preoperative teaching that needs to happen, and our discharge planning should start in our preoperative period. So some items that should be considered when we are planning our teaching. This includes fears and anxieties, an overview of the surgical procedure, an overview of the postoperative routines. So for example, do they need to be NPO? Will we have to draw routine blood samples? When can they shower? All the little details they'll want to know so they know what to expect after the procedure. You also want to talk about any planned invasive procedures. So when they get out of surgery, what lines should they expect to have? Will they have a Foley catheter? Will they have an arterial line? What kind of tubes are they going to have? Preoperatively, we want to teach the importance of coughing and turning and deep breathing. We're going to show them the incentive spirometer and make sure they understand how to use it. We also want to stress the importance of lower extremity exercises. They'll probably have stockings as well as pneumatic compression devices, but we really want to try to prevent DVTs. We also will want to talk about splinting, depending on what kind of surgery they have, and talk about what their pain management is going to look like. So this little picture just shows you all the things the nurse is responsible for prior to surgery. So make sure that patient teaching is done, make sure the consent form is signed. Our patient needs to be in a gown with allergy and ID bands on. Their contacts and their dentures should be out. Their nail polish should be removed, and they shouldn't be wearing any jewelry. It's also really important to ensure that that patient has maintained NPO status and that all lab data has been reviewed. You'll also want to verify which meds the patient can receive and then which ones need to be held until after the procedure. If this is a patient that you are taking care of on the floor versus somebody who just came in today for surgery, you'll need to get them ready to send down to pre-op. So you'll do some of the things that the pre-op nurse is normally responsible for. Ensure that all the jewelry, makeup, glasses, and dentures are removed. You need to either establish or verify that they have good IV access. For surgery, most providers want that patient to have at least 18 gauge IV catheters. You're going to perform whatever skin preparation is required. So sometimes that means wiping the patient down with chlorhexidine gluconate wipes. Sometimes you have to clip their hair. We don't use razors anymore because they can cause little microscopic nicks in the skin, and that increases the risk of infection. So instead, we're just going to trim the hair close to the skin. Remember that the skin preparation, this can be really embarrassing or uncomfortable for the patient, especially if the surgical site is in a sensitive or private body area. So provide a warm, comfortable, and a private environment during the prep, but don't ever skip this step because skin preparation before surgery is the first step in preventing any surgical wound infections. And then occasionally, you'll need to give a medication prior to taking the patient down to pre-op, but for the most part, these are given in the pre-op area or more commonly, even just as soon as the patient actually gets to the OR. As far as complications, there's not a lot that's going to happen during the preoperative period. However, a lot of the post-op complications can be traced back to an issue or a medication that was given prior to surgery. So this is part of the reason that that preoperative assessment is so important. Remember the actions of some of our classes of medications. Sedatives and opioids can cause respiratory depression. Overdoing the IV fluids can cause heart failure or hypernatremia. And some of our GI medications can cause alkalosis and cardiac abnormalities. And then additionally, many patients will be having surgery for the first time, and they'll receive medications that they've never had before. So we really need to keep an eye out for any allergic reactions.